Da-da-da. So we're going to cover, I'm going to do a little bit of background on what epinephrine is, how it works, things like that, why we give it. We're going to go through some of the steps, and then I'll do the actual demonstration. Unlike Mr. Siviter, I do not inject myself with epinephrine randomly because I do not need that kind of a jump in my heart rate. Whereas Dave will do that, and he thinks it's hilarious because he watches my face drop every single time. So I'm not going to do that, but all right, where's my thing here? Sharing the screen. Ta-da. That's pretty cool. All right. I actually quite like making slides. I like designing stuff. It's fun. All right.
If you don't want to do it, Jamie, I can inject you with an epinephrine.
See this face? See how much this face cares right now? No, I don't need it right now. If I'm ever get stung by a bee, yes, please. Please, I will welcome it, but not that. All right. Okay, so what is epinephrine? All right. So epinephrine is a vasopressor, and it is a sympathomimetic. Does anybody know what the word sympathomimetic means? Other than Andrew. So a sympathomimetic is a drug that mimics the sympathetic nervous system. And when we talked about cardiac a couple weeks ago, we talked about the sympathetic nervous system is our fight or flight response. So increase of heart rate, vasoconstriction, things like that. So it mimics that. That's why it's sometimes referred to as synthetic adrenaline. It has the same properties. And as a vasopressor, that is something that helps with blood pressure. So what it does, and any paramedic in the meeting here, both Andrew and Dave, know that they had to memorize these things. They got drilled into our heads about the drugs. The action that this drug takes, it is a beta-adrenic agonist, which means it increases your heart rate, it increases the contractility and automaticity, which is the ability for it to create electrical charge, and it causes bronchodilation. So it speeds everything up and it widens your bronchus, which is why we use it for anaphylactic reactions, because that's the opposite's kind of happening. It's also why we use it in cardiac arrest, because of that contractility and automaticity ability. It can help get that electrical component of the heart working again. Some of the side effects, if anybody here has ever gotten an epi shot, I know I have, it's fun. You can get nervous, restless, tremors, angina, which is chest pain, different arrhythmias, hypertension, tachycardia, palpitations, you feel like crap, right? So don't play with this at home.
Hey, Jamie, so
yes.
Going back to your first line,
Mm-hmm.
I'm going to go to the engineer side. So it increases electrical conductivity, i.e. allowing electrons to move better, faster?
It stimulates that part of the cell, because
Okay.
remember I showed you you had that action potential that happens. So you have the potassium and the sodium ions,
right? Okay.
And they're positively and negatively charged. So what it does is, in some technical microbiological something way, which I couldn't even tell you off the top of my head, it stimulates that to happen, which can, in a heart that's not having that happen spontaneously, cause that effect. However, too much of it's bad, which is one of the things that I learned in my protocol review that completely blew my mind is now we're only allowed to give 4 max doses of epi in a code. So there's some pretty cool things in the new protocols. If you haven't done them, do them. All right. So indications. So for BLS providers, we give epinephrine for anaphylaxis. Paramedics, we can give it for a couple other different things, but for you guys, mostly it's going to be for an anaphylactic reaction. And this is straight out the protocol book. All right. So with anaphylaxis, this is a condition defined by respiratory and or cardiovascular collapse resulting from an exaggerated response of the body's immune system to any substance. So when somebody's in anaphylaxis, it's going to be acute after exposure to a known allergen with 2 or more of the following. So urticaria, which is like a rash or hives, and mucosal swelling, edema, your tongue, stridor, lips, respiratory compromise, so you'll hear wheezing, struggling to breathe, hypotension, because they are in a shock state. This is anaphylactic shock. And persistent GI symptoms, possibly vomiting, abdominal pain, or diarrhea. All right. So we use epinephrine to kind of do a quick reversal of that. And this isn't, epinephrine, one dose of epinephrine is probably not going to sustain you. There are going to be multiple doses plus steroids. That's why everybody that gets epi goes to the hospital, because it does wear off. It has quite a quick half-life. So what are the 5 rights? What should we be doing before we give any medication?
Right med, right dose, right date, right route. I think there's a 5th one I missed. Right person.
There you go. All right. So we want to make sure we have the right med, the right dose, the right patient, the right time, right route. Okay. All those fun things. And remember, you can have one or more of these following symptoms for anaphylaxis. It doesn't just, like, you're not going to assume it's anaphylaxis because they have vomiting and abdominal pain. All right. One or more. So look at all the things that go along with that.
I have a quick question, Jamie, about, I guess, so someone who's showing signs of anaphylaxis will have hypotension, meaning they'll have lower than normal blood pressure.
It's a possibility. It's not an end all, but it is a possibility in late stages of shock, yes.
And then when you also deliver epinephrine, that will also lower the blood pressure as well?
It'll cause hypertension because it's a vasoconstrictor. So it makes the vessel smaller, but it dilates the bronchi.
Okay, that's what I was getting. So it dilates the bronchi, but constricts the vessels.
Yep.
That's a little confusing. You would think it would do all or none, not the opposite.
Well, it's an alpha beta agonist. So it works on the alpha receptor cells and the beta receptor cells, but in different ways.
If I may add, the reason for that is because it's going along the fight or flight reflex pathway. So it dilates the lungs to bring, so this is your body's natural fight or flight hormone response. So it dilates the bronchioles to bring in oxygen to help you run or fight, and it squeezes the blood vessels to deliver oxygen to the core. So it's, yeah.
Thank you. Appreciate that.
Yeah. That's why it's a sympathomimetic, because it's mimicking that for you.
So Jamie, while you're on this section here, I'd like to recite a call that we're involved in that I've used this for a lot of new EMTs. And so I'm going to describe this and you'll see where it's going. So we went for a call where a lady was having trouble breathing. It was at the steakhouse and the couple was sitting at the table and they were eating seafood and the lady had an EpiPen sitting next to her. So ironically, the medic said, oh, she's having an allergic reaction and gave her the EpiPen. No change. We got her in the ambulance. She gave a second epi, no change. And I said, what do you guys think about checking for a stroke? She was having a stroke. So it's kind of like, just because you see somebody standing there holding an EpiPen doesn't mean they're having an allergic reaction.
Right. That's why you have to make sure you have your right patient. And right. I think Dave has an amazing story about some extraordinary EMT that wanted to really give an EpiPen.
Yeah, I heard about that one. Yeah.
Apparently the person having the anaphylactic reaction was inside, but the person that met them on the steps looked like they were having an anaphylactic reaction, and the gung-ho EMT went and stabbed them. So hit the wrong patient.
I know the provider. So, but yeah, I've always used this as an example, especially people studying from the National Registry. It's like, just because you see something, don't assume that's what it is.
Absolutely not.
Right. Okay. I'll be.
I can tell you, like, when Jay had his reaction, he's had twice to an antibiotic. The second time I was with him when it happened, and I mean, he went from 0 to 60. It was Tracy, call 911. He took off running and ran and found his pin before I could even diagnose what was going on with him.
It's anybody that's experienced anaphylaxis, you know it's coming.
Yeah, and he was outside to meet the ambulance before I could even get out there with him.
Yeah, it's this feeling, you get this tickle in the back of your throat. You know, every time I get stung by a bee, I feel it. I feel this tickle in the back of my throat. I'm like, oh crap, I got stung by a bee. My throat starts feeling all funny, and I'm like, somebody get me some EpiPen, because I've been on the cusp of death from that. So ground bee, that's why I check my yard for ground bees now, and I carry a can of gasoline with me. So they go boom. Never want to get swarmed ever again. All right. So dose. So for us, now we know that an auto injector is 0.15 and 0.3, but we're going to be drawing up our own. So the dose is slightly different for BLS providers. In patients 5 years of age or greater, it's 0.5 milligrams in 5 mLs. For patients less than 5, it's 0.15 and 0.15 mLs. Okay. Now you can give additional doses with medical consultation as a BLS provider. So 0.5 and 5. And the front of our little boxes that we have actually say 0.5 and 0.15. Right? So just to kind of help us be reminded of that. All right, so route. This is an intramuscular injection. Now with a auto injector, the only place you can put it is in the leg, that vastus lateralis, the mid portion of the thigh. Because the needles, if you guys ever seen the needle in an auto injector, they're huge, okay? I actually saw one, somebody got stuck in their thumb because they put their thumb on the wrong end. Went right through. It's really creepy. So it can only go in the thigh. But for the ones that we have, they're significantly smaller. So you can administer it in the normal route, which would be on that vastus lateralis on the thigh, or in the deltoid muscle, right up here on the shoulder. So if you actually hold your fingers like a little end of a triangle and go right like that, it's going to be right in that middle part, right about there. Right.
So Jamie, when you're using the syringe, should you expose the area?
I would, because the
Okay.
needles are not that long and they won't go
Okay.
through like a auto inject will.
Okay,
Yeah, the auto injectors are so, I want to say
Right.
violent. They're so
Right.
that they'll go through and they're long, so they'll rip through that clothing. But these little tiny needles that we're using won't.
Right. Okay. Just want to bring up, yeah, because I've got plenty of training auto injectors in the building if anybody wants to play with one of those.
Yes. All right. So, equipment. So inside of your containers, you're going to see 2 needles. The first one's going to look like this. It's colorful. Don't pay any attention to the colors. Colors don't mean anything to us. All right. And you can see on the picture on the right-hand side that there's a gradient there. So when we measure out our liquid, we measure out from, if you can see there's a top black ring and a bottom black ring. We measure out where this top line is. All right. And I can put mine up really close to the screen. Okay. You can see it, top ring. All right. So you want that top ring for a pediatric patient, which is what we're going to use this for, to be at that 0.15 level. So super small syringe, and it is a super small needle, which is what, let me make myself big here again real quick, which is why we like this for kids, because this needle is super fine, super small. So really tiny. Right. So that's one of the needles. And then when I was doing this today, I realized that this syringe doesn't hold enough for an adult dose. So you'll also see one of our Vanish Point syringes in there, which is what we've been using. And the adult dose on that is 0.5. So you draw that top ring down to the 0.5.
So Jamie, it's worth noting, in case people haven't used this, that our syringes are the needle's auto retractor after it's plunged, whereas in the colored ones are not.
I was going to go through that as part of the safety thing. Yeah. So you'll have 2 syringes inside that box, one for little people, one for big people. I mean, if you guys just want to stick with these, that's fine. But I do like these little tiny needles since they come with the kit anyway, because it's a bit smaller than what is on these larger ones, and it works better on little kids. You don't feel like you're, stabbing them to death. Okay. So now we're going to do a demonstration, except I'm not going to do it on a live person because that would be horrible. Okay. So inside the kit, you're going to find a little vial. Looks like this. Okay. We always want to check the date on that, just like with any other medication, to make sure it's not expired. You're also going to find inside of there 2 alcohol wipes, all right, and your needles. So when we're doing a withdrawal from a vial, all right, the first thing you want to uncap it, and you just pull this back, and it exposes this little rubber stopper. All right, even though we just uncapped that, we're going to use one of our alcohol pads and we're going to wipe it off. All right, because we want to make sure that this is a clean environment. We don't want to inject anything that could possibly have bacteria on it, because you take this needle off in the back of an ambulance or on the side of the road, particles pop up into it, and we just want to be clean. Okay, so we're going to clean off the top of that with our alcohol wipe, and we're going to get our needle. So the first one, I'm going to do the 0.15. Okay. Now, cool thing about these vials is they're vacuum sealed, and these needles are so small that you're going to meet some resistance when you're trying to withdraw the fluid. So what I like to do is I like to pull up air into my needle of the either exact amount or a little bit more than what medication I'm going to use. All right. So I pull up the air into here, hold this at a little bit of an angle, pierce the rubber, push it in. Now I like to, you see, there's always going to be this break in the tab here. I like to have that facing me so I can see where my needle level is, so I know it's not above the liquid line, so that I know I'm pulling back stuff. So I get it in here, I push my air in, and then I can pull back very easily the correct amount of medication instead of having that resistance. And these vials are 1 ml, so you're going to have enough for at least 2 adult doses in there. All right, so you pull it back out, okay? We have our needle with our medication. Now we're going to go ahead and give this to somebody. Hold your needle like a dart, all right? Nothing on the plunger. If you put your finger on the plunger when you're taking it towards somebody, any pressure could let some of that lovely medication out. So hold it like a dart, all right? You're going to identify your site, and before you poke somebody, you're going to take an alcohol wipe and you're going to clean the area. Okay, so you go in a circular motion, outside, inside to out, nice big circle. All right, so go up here. You grab the arm, and I'm left-handed, so it's a little weird. You're going to grab the arm and kind of just plump it up a little bit so you can get it together. And I have my little dot. This is my injection dot. All right, you're going to go straight in, push the med, straight out. Don't do this and let it go like that, okay? Don't do this, don't do that, don't do this, okay? That is a needle in somebody's arm, right? So it's a straight in, push the med, pull straight out, all right? Now, these smaller needles do not retract. So when you are done with this, we do not try to take our cap in the back of a moving ambulance and put it back on there, okay? That's how you get stabbed with things. We take this and we put it directly into a sharps container. If you're on the side of the road, take this, you know this giant yellow hard case box that you have, stick it in there and seal it, and then when you get into the ambulance, pull it out and put it in the sharps container if you don't have a sharps shuttle. Because sometimes, I know ALS providers, we have a little sharps shuttle we can carry in our bag. Does anybody know Lisa Baker? She's in the waiting room. I don't know Lisa Baker. We're gonna get Zoom bombed? Anybody? No? Okay.
Jamie, a quick note on that the Sharps cap, please don't throw it on the floor.
Oh yes, don't throw that on the floor.
Because it gets caught on the auto load stretcher. 99% of our auto load stretcher problems have been caps.
Right. So that's with that little syringe. The bigger syringe for the adult patients, right? Same thing, clean the top. All right, we're gonna draw out however much we need, pull it out. Set it just like that. Because like I said, these needles are small and you're gonna meet a lot of resistance when you're trying to pull things out. So stab our thing here, push in my air. Sorry. And pull my fluid out till I get what I want. And you can always pull back a little more if you have a lot of air going on there, and give your needle a little tap to get the big air bubbles up to the top, and then prime it so that you have exactly what you need. And when it's full, you can see that the top ring is right on that 0.5. Now these needles work a little differently for those of you who haven't seen them before or haven't used one before. All right, again, pull it like a dart. We're gonna go straight in, gonna inject our med. And once we finish injecting the med, before you pull out, push a little harder. All right, this needle is going to auto reject. Oh, well, not in my dot. In a real person it does, but not in my dot. My dot's sticky. But the needle automatically retracts into the syringe here. So you don't have to worry about having a live sharps, because I can't hurt myself with this now. So got my dot sticky. That's what we use for practice. But yeah, in a real person, you'd go in, you'd push it, and then depress it all the way. That needle's going to self-retract into there, and then you don't have to worry about the sharps. After you give this medication to somebody, you should have already started to or begin transport. All right, this patient needs to go to the hospital. They do not get the luxury of staying at home after you've given this to them, right? Because they're probably going to need some follow-up meds. If you don't have an ALS provider on scene already, it's probably a good idea to call one, especially if they're having a severe reaction. Because we have other drugs. We can give more epinephrine. We can also give Benadryl. We can give dexamethasone. We can do an albuterol nebulizer. There are lots of different things that we can give to help keep those symptoms at bay until they get to the hospital. One of the other type of allergic reactions I want to talk to you guys about is one that happens with a very, very commonly prescribed blood pressure medication. Right. I actually had this happen to one of my students in class this past fall. What's it called, Andrew? I've lost my mind. It's a
ACE inhibitor induced angioedema.
Yes, angioedema. Yes. So ACE inhibitors is a type of blood pressure medication like lisinopril, right? Lisinopril. I think that's one of them. Yeah, is it ACE inhibitor? Some people have a really creepy reaction to it. My student came into class that morning, and she goes, "Jamie, I don't feel right." I said, "What's going on?" And she goes, my tongue feels weird, and and I said, "Well, stick out your tongue." And I noticed her tongue was really fat. And over the course of the next 8 to 10 minutes, it started getting fatter. And I'm like, "So what's changed?" And she goes, "Well, I started a new blood pressure medication." I said, "Oh, really? What did you take?" And she goes, "I took some lisinopril." So some people get what's called angioedema from these ACE inhibitors. And her tongue, by the time the ambulance got there, had actually swollen to the entire size of her mouth. She didn't have hives. She didn't have that wheezing, that classic anaphylactic reaction that you would see. But because of that mucosal swelling, she was having an allergic reaction to that. So epinephrine was appropriate for her. So not all allergic reactions present with the hives and the tripoding and all that stuff as well. You could have that angioedema in some people. It was interesting. And she called me from the hospital about 4 hours later. She goes, "They said it was the blood pressure medication, just like you said." And I said, "Sometimes I'm good, sometimes I'm not." Okay. So, any questions? Yes, no, maybe?
Actually, Jamie, I have one. So I would say it's definitely a no-no, but so if you're using one of the syringes that come with the new Epi kit,
Mhm.
and like we said, it only goes to 3 ml.
0.3.
0.3, excuse me.
Yes.
And we're required to give 0.5. Would it be considered a no-no to inject 3, then use that same syringe to draw up 2?
Oh, yes.
Okay.
Yeah. Once the needles pierce the skin, you don't use it again.
Okay. I just
Even though it's
want
the
to bring
same
that
person.
out. Right.
Yeah. No. You either use the little one for a 0.15 dose,
Right.
or you use the big one for either a 0.15 or a 0.5. The reason why I like the 2 is because the big syringe goes from 0.1 to 0.2.
Mm-hmm.
So you got to kind of guess on the line in between. This one tells you 0.15. So you have that immediate differentiation. So there we go. Sorry, hold it like that. So you have that immediate 0.15. And 0.15 is about half the syringe.
So when I took the class using that syringe, there was a holder for the vial because they didn't trust EMTs. I'm serious. Yeah, when you buy the kit,
Mm-hmm.
and it's
do
you know what I'm talking about?
Yeah, I know what you're talking about, but you don't have to. I don't think ours came with those. But
I
you
thought
don't
it was
have
silly
to,
too.
Yeah. Well, it's because people do this.
Right.
And then stab
Okay.
themselves. So you don't
Okay.
have to do it like this. If you feel more comfortable putting it on the table and going like that,
Right.
and then flipping it over, go for it.
Okay.
But this is just practice. I know that my one hand is going to brace this one, so I'm going to hit it right there.
Right.
It's a little bit more difficult in the back of an ambulance. And if you notice, if you hit it at the wrong angle, you see how my needle bent?
Right.
It's why they tell you to go in at an angle first
Right.
with that beveled edge to get it past that rubber, because the rubber is very thick. So otherwise you get this. And then once you've done that, you can't actually use it on anybody.
So, since we're into questions and answers, so years back, I spent a lot of time designing needles for a different product. And we used to use was called non-coring needles, which the tip was actually bent over. So
Mhm.
we don't use the bent over tip. Okay.
Could you imagine putting something that's not sharp and trying to pierce skin with it?
Right. I mean, because yeah, we're designing our septums to take that. It's actually very sharp.
Yeah. It's blunt.
Right.
So we carry blunt needles for the purposes of only piercing our vials
Okay.
because it allows us to rapidly withdraw things because they're wider.
Right.
These are tiny, and we don't trust the EMTs to switch off needles. So we're giving you one that's in there.
Right.
But yeah, it's a very, very small needle with a bevel. So all needles have a bevel on them. You guys know what a bevel is?
Mm-hmm.
Yes, I can pull a picture. I have a plethora of random things at my disposal.
So the vials that we used to use, we don't use those anymore, correct? That's been taken out of the
The ampules.
ampules, yes.
Yes. So you don't have to worry about stabbing yourself with broken glass. That
Right, and you don't have to worry about shards and all the nonsense.
Mm-hmm. Well, there wasn't too much of a worry with shards because the
Right.
needles that we're using are so tiny.
Fine, right? I know that.
Yeah.
That was the argument I got when I was talking to another group about when they didn't practice it this direction yet.
Yeah, because everyone's like, "Oh, there's gonna be glass in there," and it's like, "Oh, well, no, that's a really, really tiny needle, and we're not the only people that do it this way. And if there were, I have epinephrine on my computer.
Cost-wise, I know that the auto injector, I believe at one point is like about $500. How does this compare in money-wise? Do you have an idea?
Janet says it's a lot cheaper.
Okay, okay.
Very.
Yeah, I've seen them on Boundtree. Just the vials of Epi are like $25 a piece.
Right,
And then, the syringe and needle is a matter
Right.
of a few bucks.
right.
There's Jay's auto injector. I started
Right.
to show it earlier. Matter of fact, there's a recall on his auto injector right now. We just got a notice about it the other day. But this is the one that they prescribed him.
He has a nice generic one. I actually, because my insurance, even after insurance, I was going to be paying like $300 for an auto injector. I just told the doctor to prescribe me vials and needles, and my husband can draw it up. So
Yeah, this one didn't cost us anything. So with our insurance, they gave us 2 of them.
So this is the different parts of a needle. So you can see this bevel. There's a pointy edge, and it's at an angle. So it's cored at an angle so that the sharp point hits the skin before everything else. It makes it easier to go in. So you have the point, the bevel is the cut piece, the lumen is the hole, and then you have the shaft, and the hilt is where it meets your hub.
Because we're using those for EPA years back for hazardous waste materials.
Question for you. If we assist a patient with an auto,
Hey, Daryl, you're a little low. Can you talk a little louder?
yep, I think something's up with my computer. If we arrive on the scene and we assist the patient with their own auto injector, is that still a mandatory transport?
Yes.
Okay.
Because
okay,
it's
just wanted to confirm.
and when people are going to start arguing that I've had patients like, "Oh, you give me the epi, I'm good." I have to remind them that epinephrine wears off in about 15 minutes. And you're having an anaphylactic reaction that's global, which means it's your entire body. And that little tiny dose of epinephrine that you just got is going to last about those 15 minutes. And then that whole reaction is going to come back. And you need more drugs. You need different drugs, things that people may not carry. Even with the stuff that we have in our ALS bags, we do not carry enough to fix the problem. We carry enough to stabilize the problem until we can get to the place that can fix the problem. When I was 19 years old and I was mowing the backyard and I ran over a ground beehive. I got stung 47 times. Right? I spent 2 days in the ICU and then another week in the hospital. I had a continuous epi drip for the whole time I was in the ICU. I also had so much Benadryl in my system and so many steroids in my system, I thought I was going to eat a cow. I don't think my heart rate went back down to normal until the second day. It's no joke. I mean, my whole body, I refused to let anybody take pictures because I saw myself in a mirror and I was scary. I looked like I was about 5,000 pounds because everything was swollen. And it's no joke. Anaphylactic reactions are serious. They're priority ones. They need to go to the hospital.
So we still have a little bit of time left for our medics there. So when we're doing a cardiac arrest, and this has always been curious, and it'd be nice to kind of talk about this a little bit. How much epinephrine can you actually give in a cardiac arrest?
Currently, I can give up to, I think, like 8 or 9 doses. Starting August 1st, I give four doses total. They realized that after all the times that, all these years that we've been giving like epinephrine every 3 to 5 minutes for 30 minutes, that even if the patient comes back and we've given like 8 doses of epi, that they actually have lower survivability risks because we've given them too much of that medication at too concentrated of a dose. So they found the sweet spot is 4 doses.
When you say dose, how much is a dose? Same?
It's
1 milligram.
thank you. 1
Okay.
milligram.
Okay.
So
Which
now we can do epi drips.
puts it in perspective, right? The largest dose that we can give, and if you want to go down that path, for anaphylaxis, allergic reactions, you're talking about a concentration of 1/1000, right? For cardiac arrest and treatment of cardiac arrest, you're talking about 1/10,000, which is 1/10 of the concentration, but it's approximately 2 to 4 times the dose. So one very good way that medics can find for killing people is making a mistake and giving 1/1000 epi to a patient that is given IV as opposed to IM. The reason for the dosage difference or for the concentration difference is because when you're going into the muscle, you have a much, much slower rate of diffusion into the system than you do if you go into an IV.
Yeah.
And it has been done. I mean, medics have given 1/1000 epi directly IV. And they don't have medic cards anymore.
You see my face? What's that face?
Yeah.
Yeah, it's your body has to metabolize it when it hits that muscle. It has to break it down into little parts. So the concentration is greater for that because it takes longer. But like Dave said, you put it into an IV, it's like there, done.
So besides cardiac arrest and obviously allergic reactions, is there anything else epinephrine could be used for? I'm asking now. That's
We
just
give it for different breathing difficulties. So COPD, asthma. Here, I'll show you I have the protocol pulled up because I've been playing with it all day. And this is the 2020 protocol, just FYI. So we have allergic reactions with moderate distress. This is the ALS stuff that goes on. We can repeat every 5 minutes for 3 doses without having to consult. We're going to give them some ringers. We're going to give them some Benadryl. We're going to give them some albuterol. Things like that. We can consider Dex. I thought you used to be able to, but that might have changed again. So we got allergic reactions.
You can also use it as a pressor.
And yeah, I was going to actually pull up epinephrine. We can actually, starting in August, we have to buy special little bags of normal saline so that we can dilute it out and get down to the actual med.
Yeah, speaking of that, Chief, if when the meeting's over, if you could remind me, I was gonna talk to you about that. We had some stuff come in the mail. That's
Okay, yeah, because Janet, I know, ordered some stuff for me.
okay.
So, but yeah, we can use it for respiratory distress, asthma, COPD, and we have to consider medical consultation for people that have a cardiac history. So this is actually something that BLS providers can do. If you have moderate to severe symptoms or mild symptoms of a history of life-threatening allergic reaction, you can go to here. So it's under there. And then we have this stuff for ALS as well, CPAP, and we can do this, all that fun things, but let's get to the actual drug page. Pediatric sepsis is a new thing for ALS providers. We can give them epinephrine infusion for sepsis because it vasoconstricts, so it's slowing down the blood flow. And here is our lovely mathematicianal thing we have to do, which is really annoying. Epinephrine infusions, in shock, hypoperfusion. Love our epi now. There's so much more stuff that we can do epi with, that we can use epinephrine with, as opposed to before. So shock, hypoperfusion, and do something new. Epinephrine is generally not indicated in the treatment of traumatic cardiac arrest for adult patients. So if we have a trauma code, we don't have to use epi anymore. Oh, where am I at here?
This
So-
might be a stupid question. With the COVID, the people that are having the trouble breathing, do you use it for that?
We use dexamethasone.
Okay.
And that's instead of using an albuterol inhaler. But that's all, but an auto injector. So we can give it for anything with respiratory distress or mild allergic reaction with history of life-threatening allergic reaction, patients with severe asthma, and then the shock, things like that. So there's lots of different things that we can use it for. Because of its vasopressive abilities, it's good for helping with blood pressures and things of that nature. It actually works better than dopamine.
Great, because yeah, it said, as BLS, we know it as being for allergic reaction, but it's interesting to see, and a lot of us who've been through, working codes have seen it used and not really explained, because we're too busy doing the CPR part that we don't really get a good understanding of why you're getting epinephrine.
Well, like I said, it's because of that automaticity function that it has. It's trying to stimulate the heart to do something. So that's why if we have asystole, which is lack of electrical activity, that regardless of the fact that you see on TV that they shock that, we don't, because we can't create electricity. We can only fix it when it goes silly. So we can push epinephrine to try and stimulate the heart with our compressions, but we also push it when we have somebody like VFib or VTAC, because it can affect the contractility, which means that its contractions are more stable, which will stop that shaking mechanism and force it to contract. So it has a lot of great properties. It's a great drug, and I'm glad that they finally caught up with the times and told us that we can drip it now, because it's so much easier to calculate to do an epi drip than a dopamine drip. God, I'd be here all afternoon trying to figure that one out to help with blood pressure. It has such good functions, and it's nice to see that they're following the science and saying, hey, don't give 12 doses anymore because you're hurting people.
So what's the, here's a quiz question. What's the other name for epinephrine when it is created naturally?
I told everybody this at the beginning.
Antihistamine? No. Is right? No?
I said it's a synthetic.
It's adrenaline.
There you go.
Adrenaline, right. Okay. Excuse me.
There we go. And do you know where your adrenal glands are located?
Medulla oblongata.
In the kidneys, aren't they?
That's right. They sit right on top of each kidney.
I have a tumor on one of them.
Oh,
So when somebody says to you that they're allergic to epinephrine, they're full of crap.
actually, I have met somebody that epinephrine made their anaphylactic reaction worse.
Oh, well, that's a different story.
It was creepy.
Yeah, that's a different story. I mean, you can always have negative effects of any drug. It can go the opposite way, but nobody is really allergic to adrenaline, which, by the way, they produce. Right? That just isn't. You can't be allergic to something that you automatically make.
So Dave, what's some of the story that, of course, some of us know it, about the new EMT who gave epi? Because it's actually it's funny, but it's actually a very valid story. So
I gave a quick rundown, but I don't tell it nearly as well as you do.
What the big lady?
Yeah, the overzealous EMT.
I thought it was a young, short lady. Okay.
Well, that was the patient, right? So okay, I'll tell you. So I've got my brand new EMT. As I put it, they've got a bright new shiny EMT card with that new EMT card smell, just like you get into a car and you can, smell that it's a new car. Well, this was a new EMT, and we got, and it was when I was at 3. They're by the way, they're paramedics. So just to put a perspective on that, we got a call for an allergic reaction. As we go into the location, it turns into a priority 1 allergic reaction. And as it happened, it came out as an allergic reaction to strawberries. And as we're going there and we're rocking and rolling, it was over in 12's first due from 3. So we're going all the way across it, 301, and you know, doing about 200 miles an hour across 301. The new EMT had got the EpiPen out of the box, had taken the cap off, and was all ready to go. And all I could hear was, "Can I do it? Can 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 I get it? Can I stab it? Can I? Okay." I'm like, just chill out, right? So we get eventually to the house, and I just heard, you know, this sounds like Bart Simpson in the back. Are we there yet? And they rush out, and I'm like, I swear to God, if you stab yourself with that, you know, I am going to make sure I stab you in the eye with it by the time you get there. So I threatened them, just chill out, calm down. You've got to make sure that, you know, you're doing the right thing. We get there, there's about it's one of these houses that's got split level. So they've got the downstairs basement, they've got the upstairs bedrooms, and the stoop goes up to the middle section so that you either come down from the bedroom or up from the basement. And you know, there they are, and it's twilight, so they're framed in the door. They're framed in the doorway, and all that we see is this very large lady who probably weighs, I don't know, 300, 350, in the doorway, holding her chest, having trouble breathing. The EMT runs up the stairs. No, everybody at this point thinks they're going to fall on the EpiPen. No, they don't. They run up the stairs, and all they hear from the patient is, what the lady was trying to say. So they then said, "Don't worry, ma'am, we've got this." Wham, EpiPen straight in the thigh. No problem at all. What could possibly go wrong? Just in time for the woman to say, "My daughter's downstairs in the lounge and she's got an allergic reaction from strawberries." And I hear this and I'm going, oh crap, right? So when you do the 5 R's thing and you think, who could possibly get the wrong patient? I mean, why would they make one of the R's the right patient? Well, I've actually seen somebody physically stab an EpiPen into the wrong patient simply because they were out of breath because they'd come up to open the front door. And at that point, I quickly thought about this and got on the radio and calmly said, "We have 2 allergic strawberry reactions. Could you send another ambulance, please?" and we then transported 2 patients to the hospital. But yeah, it can happen. You can get the wrong patient. Let them speak if they can. And that person is a paramedic today.
I still to this day don't know who it is because nobody will tell me, and I really want to know.
They're never going to do it.
I want to know. And if it's somebody that started there that is now a paramedic, it has to be one of the 2 people I'm thinking of. I just haven't confirmed it in my mind yet.
Nope.
I'm just not going there.
Nope. Won't tell you either. I know who it is and we'll tell you.
Not going there. But always good. Now I will say there was somebody else at 3. What was his name? He was like as old as dirt, and that was 10 years ago. He used to be a captain there. And I saw him stab an EpiPen through his thumb. And,
Yeah.
and he put his finger over the thumb. The epi injector injected and came straight through his thumb and did a perfect 10 to 15 foot arc and hit the wall on the other side.
That's why we hold EpiPens like this.
Yep.
Like we're gonna stab somebody like with a knife, not like this.
Yeah.
Stab.
Put your thumb on the top.
That's what we do. We always train everybody in our first aid class exactly how to use it properly. And that's why we have a bunch of trainers.
In the heat of the moment, they'll forget and they'll stick it through their thumb.
So.
It goes right through the nail, whole thing.
Oh yeah. Any other questions regarding epinephrine? Yes,
That
ma'am.
was really good, Jamie. Appreciate that.
So,
So-
next week, Andrew is going to amaze us with his lovely presentation on sepsis. And then the following week, you want something on strokes? I can do strokes for you,
Correct.
Barry.
If you want to do strokes, and remember, and this is what we really preach, like a lot of the new EMTs, that the key point is not to also make sure to check blood sugar.
Oh,
Because
absolutely.
I've watched medics screw this up many
Oh,
times. I've been on scenes and they're like, I said, well, did you check the blood sugar? And they're like, so yeah.
Tell you what, I'll do strokes in 2 weeks, and then the following week I'm gonna do heat stroke just because it's hot outside.
That's a very good one. Very good topic. And then
Pickles and watermelon.
When we do strokes, can we make sure to do the new, I know last year they did the new like posterior cerebellar stuff, and I actually called one the other day, and it's kind of cool, but I want to learn more on it because it's, you know,
I will look and see how in depth that is, and I might include something for you.
I know I've listened to some podcasts about it, and it sounds like some complicated stuff, but you know, it's why I want to know more about it. So
So
Daniel
Jamie-
told us that if you shake your head really fast and the headache goes away and then it comes back, you're having a posterior something.
So I'll start breaking down the protocol book for BLS. So as you guys wrap up the stroke and the heat stroke, I will start working on, like you said, we'll break down the protocol book and take a section at a time and kind of highlight, really just talk about it. I mean, that's the whole goal to it. That's the same thing we do in OIC classes. Like everybody's got a different opinion. Talk
I think
about it.
that'd be good because then we can do a section on like abuse and neglect, which we may not see
Right.
that often, and some of the things that we don't do on a regular basis. So
have we thought about putting out the training for like the whole county